Good afternoon. I want to call our meeting to order, the Health Subcommittee of Appropriations. Thank you all for coming. Any of you folks that are standing in the back, if y'all want to grab a chair on the back, you're welcome to do that. If you don't want to stand up, we'd be glad to have you sit. And there's a lot going on. You're going to have some members sort of coming and going. But we're going to go ahead and start. We've got a lot to cover, and it's kind of a condensed version today. We got a lot of things going on. We've got others wanting this room as soon as we get through. So without further ado, we're going to call on Commissioner Berry with Community Health.
Mr. Chairman, thank you very much. And I understand we've got a full day today, so we will get right into our numbers. Lisa Walker will go over the financial requests and the recommendations that we have. Before I turn it over to Lisa, though, I did want to just take 2 seconds to recognize our team at DCH and what a remarkable job they're doing, focusing on 3 priority areas: communication, teamwork, and customer service. Certainly, I want to extend the offer that if you have challenges that you need to talk with us offline on, we're available. Lisa Marie is here and available really during session 24 hours a day, 7 days a week. I'll commit you to that, Lisa Marie. I also think it's really important to recognize Dr. O'Neill and his team, and I know you'll hear from them. We had a medical emergency earlier today at the department, and the Department of Public Health, under his leadership on 2 occasions now, has sent nurses over, and he personally has come over to help us when we've had to send people over to Grady. And so, Dr. O'Neill, thank you very much for you and your team and all that you do. And I bring that up because I think it's important to convey state government works well together, and the departments are working well together. And when we have each other's cell phones, good things can happen. And so you'll hear from Lisa the dollar request. I did want to just touch bases on 2 big initiatives. One of them is a quality unit that you'll hear about, and there's a tremendous amount of detail in the packet that goes with that. But the quality unit is something that is extremely important. It focuses on the partnership and the oversight that our department provides to the Department of Behavioral Health and Developmental Disability for individuals that are on the comprehensive waiver, along with all of the other waivers. But this is really an emphasis on those individuals that are on the comprehensive waiver, and making sure that we can ensure the health and safety of those individuals as they have transitioned out of state institutions. We have a very strong relationship with DBHDD, but what CMS has requested and required is that we develop a plan to demonstrate how we hold that department accountable for those waivers. They administer the waivers, we provide them those waivers, but we have to provide the oversight. So you'll hear a pretty significant dollar request for that quality unit. It is a CMS corrective action plan requirement. We'll be happy to answer any questions you may have about that. But that's something that's fairly new. I know we've had some brief discussion about that previously, but I did want you to be aware of that. And now I'll turn it over to Lisa to get into the actual numbers, and then we'll be able to answer any questions you may have. If we can't answer them, we'll get those answers back to you immediately or as soon as we can.
Okay, that'll be great. And we'll have the presentation, and save your questions until we finish the presentation, then we'll come back and take questions from the committee.
Thank you.
We'll begin with the fiscal year of 2019, and the first of those recommendations will be 17.7.1, 17.8.1, and this is benefits growth in the age, blind, and disabled Medicaid program and the low-income Medicaid program. And the request for that in fiscal year 19 is $45,694,000 in the benefits program. The second of those requests is for benefits previously funded with tenant. This is the replacement of tenant funds that was appropriated in fiscal year 18, and that's item 17.7.2, 17.8.2, and the recommendation is in the amount of $92,371,000. The next item is 17.7.3, and that's a 4.3% increase in nursing home reimbursement rate. And for fiscal year 19, that amount is $16,894,000, and that's an increase in nursing home rates across the board. The next item is 17.7.4, and that's personal needs allowance. And the personal needs allowance is actually money that is retained from patients' checks to go into a personal needs allowance to pay for their, they might want greeting cards, they might want flowers, but it's to address their personal needs while they're in the nursing home. That amount is appropriated in the Department of Human Services. This amount in the Department of Community Health is actually to offset that increase in the personal needs allowance for the reimbursement of their care while they're in the nursing home, and that recommendation is $803,000. The next item is 17.7.5, and it's a rate increase for alternative living services, and that recommendation is $3,378,000. And that actually is taking the reimbursement rate from $37 to $50 in the Source and CCSP waiver program. The next item is 17.7.6 for liability insurance for nursing homes. The recommendation is $5 million. This is to remove the amount from it that's in a base rate to make it separate for the nursing homes to have liability insurance for increased risk. The next item is 17.7.7, 17.8.5, and this is the federal medical assistance percentage adjustment. The federal percentage decreased, so that made the state match increase, and that recommendation for FMAP adjustment is $57,881,000. 17.7.8 is nursing home provider fee adjustment. Each year we have to provide revenue estimates to the Governor's Office of Planning and Budget, usually it's in August, to reflect the actual collection of nursing home provider fee. And it was a reduction of that provider fee from the previous year to last year of $14,142,000. But we've been working with the Nursing Home Association to help recoup that money, and we have been in communication with the Nursing Home Association as it relates to that. The next item is 17.7.9, direct graduate medical education expansion. The recommendation is for $1,700,000. And that's for additional funds to increase Medicaid GME costs due to additional residents at Georgia teaching hospitals. And that's primarily 360 additional residents. And the recommendation is for $1,700,000. The next item is 17.7.10, 17.8.4. And that's hospital provider fee adjustment. Once again, this is another revenue estimate we have to provide to the Governor's Office of Planning and Budget each year. And the adjustment in that particular revenue is $15,294,000. 17.8.3, the health insurer fee. This HIF was a ACA mandate fee, which was temporarily suspended in state fiscal year 17, and this is the replacement of those funds for the payment of that fee at the end of this state fiscal year. And that recommendation is $32,220,000. We move into the Administration and Program Support Program, and beginning with recommendations for that particular program, the first is 17.1.6. It's the quality assurance within waivers. We received a letter from CMS, I want to say it was last year in August, as it relates to a corrective action for our oversight of our waiver program, and we submitted a corrective action plan to CMS as it relates to that, and the recommendation for that particular request is $1,121,000. 17.1.7, Enterprise Data Solutions. This is a procurement that will replace our old legacy system, which we call Decision Support System. It was to fully support analytics, data warehousing, and modeling capabilities, and allow external systems to interface with the systems to capture data. And the recommendation for that request is $1,902,000. 17.1.8 is electronic visit verification. The electronic visit verification system is a system that was required by the 21st Century Cures Act, which was signed into law December of 2016 to go into effect January 1, 2019. This particular system will allow home health care visits to be documented when they go out and visit patients in their home. The next item is 17.1. Well, that recommendation is $894,000. The next item is 17.1.9, and this is just a functional alignment within our program, Transfer Health Information Technology to admin. It is currently sitting in the program that has State Office of Rural Health, but Health Information Technology is an IT-related function, and we are realigning those functions with our Office of Information Technology, and that recommendation is $1,762,000. The next item is 17.1.10, autism capacity building. This recommendation is $847,000, and this particular recommendation will help expand the provider network and children's access to the autism treatment program as it rolls out and become in effect. The next item is 17.1.11, ongoing Medicaid information technology projects. The recommendation is to utilize existing funds of $111,000. And the MIDA projects is what we refer to as the MIDA projects, is to help streamline and advance the development of integration, standardization, and automation within the Medicaid enterprise. It's in its third year and need additional funds to expand the project. And that recommendation is, once I said, it's once again, is utilize existing funds of $111,000. 17.1.12, right from the start Medicaid caseworker retention. We have an 8% turnover rate within our right from the start Medicaid program, and this amount of utilize existing funds of $67,000 will allow us to provide salary increases for the entry-level workers, so we won't lose those workers to other agencies. The next item is 17.1.13, long-term care provider background checks. This will allow background checks for personal care homes, assisted living facilities, and community living arrangements, and state funds is needed to maintain background checks, and this will include additional 4 staff to help do those background checks, and this is to utilize existing funds of $962,000. The next item is autism program coordination, and this is for a position for an autism program coordinator to help support the autism initiative within Medicaid, and the recommendation for that program is utilize existing funds of $50,700. Healthcare access and improvement is the next program, and within health access and improvement is the State Office of Rural Health and Health Information Technology. And the first of those items is 17.4.3 for health care for the homeless program, and the recommendation is $66,371 to help continue the operations of that program. And that particular program provides health care services to the homeless in the Atlanta and the Savannah area. The next item, as I previously mentioned, that was in Department of Administration program. This is showing the reduction in this program transferred to admin of $1,762,000, moving health information technology to the administration program. Next is the healthcare facility regulation. This is the regulation of our nursing homes. And the first of those items is 17.5.3, and that's the annual on-site inspection of narcotic treatment programs, and the recommendation is $244,000. And that recommendation is for additional 3 staff to help support the surveys of narcotic treatment programs within the state. And that's, once again, that recommendation is $244,000. The next recommendation is statewide adjustments. These statewide adjustments are actually recommended from the Governor's Office of Planning and Budget that go into programs to help support operational costs, such as personal liability, merit assessment, cyber insurance, and things of that nature. And the recommendation is a reduction of $44,578,000. That ended most of the recommendations for our Medicaid and administrative programs. The next is State Office of State Health Benefit Plan, SHBP. And most of these recommendations in the amounts column, you will see yes, and this is because most of the money that goes in this program comes from the employer share being paid to subsidize healthcare insurance for state employees, and for state employees' premiums also. First of those items is 17.10.1, and this is to reflect projections and growth within the state health benefit plan, and the recommendation is $263,591,000, and this projected growth is for membership growth, medical services utilization, and medical trends within the state health benefit program. The next item is 17.10.2, increase autism benefit to age 21, and this is to keep in parity with the Medicaid program of increasing the age to 21, and the recommendation for SHBP is $2,200,000. 17.10.3, 2018 Kaiser procurement savings each year. When we enter a procurement and contractual services with our providers, each year there are renewals. And when we go forth to do those renewals, there are usually savings as it relates to that. And with the procurement savings related to Kaiser, we saw that there was lower than anticipated rates than what was originally expected. And the savings generated for that program is $6,980,000. The next item is 17.10.4, 2018 Medicare Advantage procurement savings, and this is procuring the vendor to offer the Medicare Advantage plans to those who are 60 state employees who are retired and 65 and above. And these are savings that are attributed to Medicare Advantage rates for the plan year 2018. And there's an expected savings as it relates to that of $67,555,000. 17.10.5 is the next item, 2018 non-Medicare Advantage contribution change. This is the premium change for state employees who are under the state health benefit plan. That will be a small premium increase for those employees, and the recommendation is $12,100,000 for that particular item. The next item is 17.10.6, and this is 2018 Medicare Advantage employee contribution change. And this is the employee contribution change for those retired employees who are 65 and above and who receive a Medicare Advantage plan. And there was a small premium change for those employees, and the recommendation is $499,000. The next item is 17.10.7, pharmacy benefit manager procurement savings. We changed pharmacy benefit manager vendor this year to CVS for 2018, and savings usually comes once again from procurement of those services, and this can come from improved discounts or either reduced administrative fees as well as improved rebates, and the recommendation for that item is $3,597,000. That's the last of the recommendations for the Department of Community Health, and if you have questions, we open for questions.
Okay, thank you. Do we have questions from the committee? Let's see. Representative Taylor.
Thank you. I'm not sure if it came on or not.
I can hear.
Okay. The pharmacy benefit program, I realize that was a big change that we made this year. We have a new provider. But the amount that was in the adjusted budget, which was 6 months worth of savings, is almost the same amount as what it would be for the whole year. And from the size of our group and the benefits that were changed, there should be a much larger amount of savings, I feel like. I'm not sure what this was based on, but I would like to see some information to see how it was based for. I would expect to have had a larger reduction.
Why don't we'll get that information and we'll come over and bring it over either this afternoon or tomorrow, and we'll schedule
Okay,
whenever's
that's
convenient for you.
fine.
Yep.
There is a comment related to that. In the amended year bill, although it was 3 million, I think 100 and some thousand, although it's the amended year, it's still 12 months that we base that projection and savings on in the amended year. There are some items we just look at and as it relates to 6 months, but that was a 12-month savings as it related to PBM.
Okay, when was the PBM change made? It's just been made, hasn't it, January 1?
It was made January 1, but we go into the processes of deciding what those changes are probably 7 or 8 months before January 1 rolls around.
Okay.
But we can provide additional
Okay,
information.
it's just that it became effective January 1, and the amended budget covered from January, projecting what it would be through June. So this would be June through next July, or next July through next June. And I would have thought it would have been a full 12 months. I get it. We can go look over this offline. But even at that, the 3 million does not seem sufficient for the size of the group.
Program. Okay.
Thank you.
Thank you.
Representative Dollar.
Thank you, Ms. Walker. Thank you, Chairman. I came in a little late, so you may have mentioned it before I got in. Can you talk about the $20 million settlement with Cool Smiles dental provider?
I didn't. I'm sorry. Where?
Can you you may have talked about this before I came in, but can you address the $20 million settlement with Cool Smiles? I believe it was.
Go ahead.
I'm not familiar with that.
I'm not familiar with that one either.
Okay.
So we did
Somebody
not
brought
touch on
that to my attention, and I was curious to see if y'all would talk about it and to see what those funds are being used for.
Why don't we touch bases maybe afterwards, and
Okay.
then if you could reach out, or we'll get Lisa Marie to reach out and see where you got that, and then we'll see if it's ours or if it's somebody else's. But
Okay.
I'm not.
Thank you.
I'm sorry. I'm just not familiar with it.
Thank you.
Anyone else? Would you speak just a little? There are a couple of pretty significant numbers. I think just round numbers, they come to about $57 million in the hospital bed fee as well as the nursing home, and that one is going up each year, and then one seems to be in a negative position there. And I realize there's a difference. It's sort of apples and oranges. Could you talk to that a little bit, help us maybe a little better understand what's going on with that?
With the nursing home provider fee, each year, once again, we have to provide those estimates to the Governor's Office of Planning and Budget. And based on how those are collected, when we ended June 30th of 2017, the collection was $15 million. In the amended year, it was 15, and this is a projected number for 19. And it was $15 million compared to the previous year. When we ended June 2016, we had collected $117 million in nursing home provider fee. But when we ended June of 2017, we had collected $156 million of nursing home provider fee. We've been in conversation with the Nursing Home Association in terms of those collections. I've been talking to Tony Marshall. We provided him a list of the nursing homes and the outstanding amounts at a point in time, and that point in time was August. And there have been collections made since then. And I don't want to speak off the cuff. I was told, 9.2? Since then, 9.2 has been collected as it relates to nursing home provider fee.
Okay, but there's a difference in the way that's done, I think,
Yes,
and
it
correct
is.
me if I misspeak. One is based upon the net revenue, like the
Yes.
hospital bed
Hospital
fee,
provider fee.
and then the nursing home is
Based on bed days.
Right.
Mhm.
And so if the number of beds that are occupied goes down a little,
Yes.
then that would reflect some of that too, right?
Yes.
Okay. Anyone else? Representative Gardner, push the button there.
Thank you, Mr. Chairman. Thank you for this.
Use this one right here. That one's not.
I got
Yeah.
all kinds of
Yeah.
mics here.
That
Thank
was,
you.
let's
Thank
try that one. I think
Again, I was curious about the pickup on the utilization of the benefits for the autism program. And I think I asked at the last meeting to see how much pickup there had been, how much expenditure there really has been in the amended budget. And So kind of a year-to-date report would be helpful to me.
I can repeat. You want to know the autism spend as it relates in terms of how it picked up on Medicaid or state health benefit?
Both of them,
Both of
actually.
them. Well,
Yeah.
since autism just rolled out with Medicaid, we have to wait on what the utilization is on that particular item. But for state health benefit plan, if I'm remembering correctly, I think the first year autism was put in state health benefit plan, I think it was just 500 or 600,000 in terms of utilization. That has increased to almost $1 million since its implementation. I'm not quite sure in terms of the number of kids who are receiving those services, but we can follow up on that.
If you would follow up with me, I remember there was a $4 million line item at the beginning, and it wasn't utilized as much, probably because the services are not available. I don't know, but I'm wondering if it's picking up in both Medicaid as it develops and also in the state health benefit plan. Thank you.
Representative Gardner, I think the other big point that we'll really begin to see some movement on autism now, beginning January 1, will be on provider engagement, embracing new or enrolling new providers. And I think this year we will see a significant increase in the number of children and families that are accessing that service. It's an exciting time for those families to be able to get some services that they've been needing for years. Yes. Yeah, I mean, the partnerships between the state agencies and with the provider networks, people that have historically dabbled in this, who are now going to become full-fledged partners in it, and those existing partners who really have some great insight into how you go about delivering best practice. I believe everybody has come together to create a really robust, that ultimately will become a really robust continuum of care. It's going to take a little bit of time. I don't want to overpromise, but I think we're on the right path moving forward to be able to serve a lot of kids. But it'll take time to build out the services.
And the crisis center for autism is in your budget, or is
No.
It's in DBH?
Yes.
DD?
I don't know anything about that department.
I'll bet.
No, I'm good.
Well, evidently y'all done a good job there. I'm sure we'll think of some more. And I'll mention also that we'll be meeting tomorrow in this same room, just to remind you, at 12:30 for public comment. So anyone who wants to come and have some input and be heard on any particular issues in this budget or in public health that we'll go through, we'll be here, and there'll be a sign-up sheet 15 minutes before we start, so anybody that wants to make a comment will be able to do that. But Commissioner, anything else you want to share
Mr. Chairman,
with us before we
it's
leave?
an honor to work with you and all of the committee members. We have a great committee, and I'm grateful for each one of you. Thank you very, very much.
Thank you, and thank you, police officer. Okay, we'll move right along with public health. Dr. O'Neill. Dr. O'Neill, welcome.
Thank you. Chairman and committee members, before we actually get started, I'd like to just sort of affirm what Commissioner Berry was saying at the very beginning. I don't know of any time that I've seen the four health agencies that are at 2 Peachtree work more collaboratively than in the last year. I'm not sure what accounts for that, but I think that it's really a very wonderful situation that can only get better.
Well, I think it's the leadership in those agencies that has a lot to do with that, too.
Thank you. In public health, once again, I would remind you of what we're calling the DPH initiatives, but these are really our priorities, and they have not changed. We do not anticipate that they'll change for 2019. The prescription drug monitoring program, which legislature passed from GDNA to public health just as of July 1 of this past year. The cardiac care network formation, which was also a legislative act in this last year. Early brain development, which I think is one of the most important things that public health will deal with over the next decades, is still a high priority for us, and we have many programs that deal with that. Maternal mortality is an area that concerns me very much, and we're not going to be asking for any additional funding in 2019, but I did want to mention it. We do have some grant funding that will continue for a period of about 5 years, and I just wanted the committee to be aware that this is something that we're watching very, very closely, because Georgia cannot be proud of the numbers that we've had with maternal mortality, and we need to do a lot more to correct this. And the last thing I'll mention also, there's no ask financially for this, but I did want to mention it before closing, and that's our intent to become much more focused as an academic health department. And I'll tell you a bit more about that as we proceed on. In terms of the ask, we're asking for an increase in funds for the Office of Cardiac Care of $355,000, $406 actually. And basically, this will allow us to completely fill out the 4-person office of the cardiac care group. And once we have that office in place, we can begin the actual designation of either level 1 or level 2 cardiac centers across the state of Georgia. So we're looking forward to being able to do that very shortly. We're also asking for an increase in funds for the prescription drug monitoring program, and I think you're all very familiar with that. This is another area that's extraordinarily crucial for us here in Georgia, and we'll talk a little bit more about why it's so crucial as we get into this, but our ask is $626,545 for 2019. Another ask, and you've heard a bit about autism in the previous presentation, I will mention this again here. We're looking at requesting $100,000, and the purpose of that will be to work a grant with the Marcus Autism Center, which we think will help us begin to expand capacity in dealing with autism in Georgia. Statewide changes I'm not going to go over because those are essentially fixed for all the agencies in Georgia, so I'll spare you that. Let's drill down, though, on the Office of Cardiac Care. Personal services will account for almost $400,000 of the ask, and basically there we hope to have in place essentially a program manager. We hope to have a cardiac epidemiologist. We hope to have a registrar. We actually already do have that person in place for the registries, both the pre-hospital registry as well as the in-hospital registry for cardiac events, as well as an admin person to assist those entities. We did receive, as I'm sure you're well aware, $106,800 previously in an appropriation for the beginning of the formation of this network, and that funding was used just to hire the registrar for the system. He hit the ground running, and I think we've achieved a great deal in the first year of his employment. 2019 Governor's recommendation total $355,406, total funds $462,206. Look down at the bottom of that page if you would. I've already mentioned the staffing of the cardiac care system, and I think you understand that. The other thing that I wanted to mention, though, is something that we hope to do in terms of the site visits, the surveys, the inspections, whatever you choose to call them. As we begin to look at hospitals that hold themselves out to be either a level 1 open heart center or a level 2 PCI center, percutaneous coronary intervention center, we want to do something similar to what we've been doing for years in the trauma program, and that's to have a mixed site team that's half state funded or state-funded people, but also half made up of peers. I think that that has proven extraordinarily valuable to us in trauma. What I've seen happening is that the site visitors from peer sites actually tend to go away learning as much as those sites that they're visiting. They take back best practices to their own facilities, and I think I've seen tremendous growth in trauma because of having that type of a hybrid inspection team. And we want to do the very same thing with the cardiac system as well. And as we do with so many of our specialty centers that we in public health designate, we have a cycle of 3 years where we do redesignation visits. So this will be an ongoing program where not only is it a one-time visit, but it's ongoing to be sure that those centers maintain their proficiency. Next page, please let us drill down also on the PDMP. Personal services for this will include the coordinator for that program, and that person is already on board doing a really great job, I think, along with 2 temporary folks that have been working with her. We probably will bring one of those people on as a full-time employee and continue to have one as a temp in the future. The temps are basically the ones that are manning the system day by day, assisting providers if they need help getting registered in the system, or pulling data for us as we request the data. So that will be an ongoing requirement for us. The registry contract with APRIS, which is our vendor, $310,105. And so far, the relationship that we've had with APRIS, I think, has been very productive. It's a very good relationship. And right now, I've forgotten the total number, but I think it's around 45 states that are using the same vendor. So essentially, we have good company out there with that. Total cost for this would be $626,545. One of the things that is not mentioned in this, but I do want you to be aware of it because I think it may be something that we'll be looking for help with later on. We don't have the ability to do it right now because the law will have to be changed before we can do it. But one of my goals eventually is to be able to integrate the PDMP with the electronic health records in practitioners' offices. Legally, we're not allowed to do that yet. We do have legislation pending, which I hope will allow us to do that in the future. And when that comes about, we probably will need additional funding in order to be able to do that from an IT perspective. I think that's going to be extraordinarily important in order to be able to maximize the ability of particularly physicians to limit the amount of time that it takes to find out what's in the PDMP. Right now, they have to go into a separate portal to find out what's in there for that particular patient that they're treating. What I would love to see is that at the time that they are at the point of prescribing in the electronic health record, that on another part of that screen, perhaps the upper left-hand corner, they'll be able to see PDMP information on that particular patient without going into a separate portal. So that's our long-term goal there. I would also urge you to look at the bottom of that sheet because I think it really frightens me when I think about the numbers as they have been growing in the state of Georgia. Look at the information 2010 to 2016. Total number of opioid-involved overdose deaths increased by 117%. 426 to 929 deaths in 2016. And that may be underreported, actually. So I think the number is astounding. Georgia has not been spared this horrific outbreak across the country. That's a 4.3 to 9.1 deaths per 100,000 persons rate as well. So a lot of work that all of us need to do. This is not just a public health area. This is a statewide initiative. In fact, we in public health are charged with helping to craft the strategy for what the state is doing. This is not a public health strategy. It's a statewide strategy with multiple stakeholders that have to be involved if we're really going to make a difference in what we do here. And the other thing that I would urge folks as yourselves or policymakers, please don't think of this just as an opioid crisis. Think of this as an addiction disease crisis. The one thing that I don't want to see us do in Georgia is to plug the hole with opioids, only to have 2 more outbreaks in other areas such as heroin. So I think we need to be thinking of it very broadly, not just as opioids. Next slide, please, on autism. Once again, this is an area where I think the health agencies are working very well together. What we are in public health hoping to do, we have a request for $100,000, and that's basically to have a contract with the Marcus Center, Autism Center at Emory, in order for them to expand training that will ultimately help improve capacity here in Georgia for dealing with autism, which, as you well know, is a growing phenomenon that we're dealing with. And we once again will use existing funds, and you heard this same number mentioned, I think, in the previous presentation, but our contribution will be $50,700 worth of funding for this program support coordinator. Maternal mortality, once again, there's no ask in terms of funding for 2019 here. We do have a 5-year grant, $200,000 a year, that I think is really going to be helpful for us as we begin to try to improve our ability to look at the data and see what's really going to make a difference. I mention this because if in fact we are successful, we have now 10 birthing centers that we have rolled out our AIMS bundles in. Those are essentially guidelines for those centers to use, focusing on 2 of the most likely causes of death at the time of delivery or around that period. One is hypertensive deaths, and obviously the other is hemorrhage. And other states have found this type of program very, very effective. If the data shows that it's as effective as I think it's going to be, we'll probably be coming back in the next fiscal year asking for additional funding to move this out to all birthing centers in the state of Georgia. So I mention that because I get very embarrassed with my colleagues in other states to admit the mortality rate, maternal mortality rate in Georgia. This is just not excusable. And in closing, I wanted to just mention also the academic health department. Again, no ask financially at this time, and there may not ever be an ask here, but I think that of all the things that I can pass on to the next commissioner of public health, the one thing that I want to charge that commissioner with is looking at the opportunity for what I'm calling the next acceleration phase for improvement in public health, and it will be for us to truly become identified as an academic health department. And what that really means to me is that we'll be working much more closely with academic partners across the state, sharing workforce, allowing those facilities that need to have training grounds for their students, their undergraduate students, their master's level students, their doctoral students, their professional students, to actually work in public health. That's going to help us particularly, and I don't think I heard very much about this when we were looking at all the concerns this last summer of increasing access to care in rural Georgia. I think this may be one of the most important answers in addition to telemedicine and telehealth that we can offer. I think our schools need places for training. Public health needs those resources to help the folks throughout the state of Georgia. So this is one of my long-term goals, and I hope to be able to pass this on to the next commissioner. Last thing I will mention is to just point out that 37% of the funding in public health is state funding, whereas 60% is federal funding. And constantly we are looking for other opportunities with grants to increase that federal portion. With that, I'll take any questions.
Okay, we do have some questions. Representative Hawkins, you have a question?
A quick question for you, Doc. Yeah, I see the prescription drug monitoring program, the price, the cost of this is escalating, and I understand the problem and I understand the amount of work you're doing. As we talked about earlier about the real-time program, which was estimated around $500,000, are we ever going to take a look back at that and see if we have cost savings by going to a real-time?
Yes, I think obviously we're not at real-time yet. We're right. Closer than we were, and I was very negligent not to mention that that's one of our goals too. Okay. I don't have an ask for funding for that right now. Right. My next ask, as I said, will be to do the integrated PDMP electronic health record. Right. But I think that probably will also almost go along at the same time with looking at moving closer to real time than even we are now. And obviously when we get there, we're going to have to look back and see, is there a significant cost savings, or is the trade-off going to be in improved detection?
Right. I'd be interested in that, and also we stop the drug. At that point, the patient never gets the drug. But at the same time, I hope it can be done in a way that the pharmacists are not bombarded with extra work that makes it really crippling on them. I think what we saw visiting states, that's probably 10 years ago, it appeared that the pharmacist just typed in the name, patient, the doc, and the drug. The drug triggered the computer, centralized computer, to kick on and told the pharmacist right then, you know, this patient just got this 2 days ago, you know, from another doc. It gave him the information. That seemed to me to be a very viable program. You know.
I think you're identifying something very important. And one of the things that I hear you saying also, which is my plea, and that is I realize the importance of doing what we have to do with PDMP, but I also do not want for us to constantly be adding things that are going to be just more bureaucratic requirements for either the pharmacists or the providers.
Right.
I think that we can get into terrible downsides when we do that.
Right.
So I think we've got to be very careful there. And if there are information technology answers to make this much more user-friendly, much more real-time, that's the way we have to be going.
Thank you. Appreciate you looking at that. Thank you.
Thank you, Mr. Chairman, and thank you for being willing to step up to be the commissioner of the department. I have one specific question and one sort of big picture question. The first one has to do with Babies Can't Wait and the reimbursement rate for the OTs, PTs, and speech and language therapists that under Medicaid have one rate and in Babies Can't Wait have another rate. Have you given consideration to make those rates similar?
Yes, we have. And in fact, I don't have an answer to how close we are to doing that, but after a previous presentation, I had discussions about that very issue, and we're working now, as I said, I think very collaboratively with Medicaid. So I'm hoping that we will be able to do something effective there.
Great. The other thing that worries me is when I look at this chart, how much have you already lost in terms of federal funding that used to come from CDC?
My best guess, and Dion will probably correct me if I'm out of the ballpark, but looking back over the last 5 years, I would say in most of our grants are CDC, although we have some HRSA grants, we have very limited amount of NIH money because we really are not a research organization. But I would estimate that we probably lost 7 to 10% of grant funding. Now, the other thing that folks need to understand is that part of this occurred in response to the Affordable Care Act, because there was an expectation that when that went through, that there would no longer be any need for clinical services in our grants. And many of our CDC grants previously had monies that were allowed for us to use in the health department for clinical services. That's no longer there in most of our grants. That's been wiped out. So that accounts for most of our loss.
Thank you.
Any other questions? Okay. Dr. Neal, talk to us a minute, if you would. Your department, you have been out there on the front line as we've had to deal with the Zika virus and now the flu. Kind of bring us up to speed, if you would, on what's going on around the state and how the department is reacting to some of that and how it's affecting you as far as maybe in the budget or whatever.
I think we're experiencing here in Georgia very much what's being seen in the rest of the country. Probably the highest numbers of seasonal flu cases that I can ever recall in my many years in healthcare. And whereas we thought maybe 2 weeks ago that it had peaked, that's not the case. It had continued to escalate. I don't know what this week will show, but last week it continued to be very high, widespread throughout the state of Georgia. The numbers of deaths, I don't have this week's report yet, but as of the end of last week, we were up to 55 deaths here in Georgia, one of which was a pediatric death, actually a teenager, a 15-year-old. I've heard anecdotally that there might be another death, a pediatric death, in a very young child, but don't have that data yet. The interesting thing from my perspective is that we have seen a lot of instances of flu in individuals who have in fact received the flu shots or immunizations. But the good news is that if in fact those individuals did receive immunizations, the course of their illness and the severity of their illness seems to be modified in a positive way so that it's not as severe or as long. So that's good, and that's why we're still continuing to recommend for those that have not been immunized to get immunized. Sadly, we don't have any control over what's happening in social media. And some of the messaging in social media is just off the wall, astounding. Things going around like, don't get the flu shot, this is a conspiracy, it's poison, they're trying to kill you. Crazy stuff like that, which is very hard for us to countermand. I did a press conference last week to try to do some countermanding of it, but you never know how effective that is. The hospitals, the emergency departments have been extraordinarily busy. Those of you who are in the metro area know that Grady had actually been able to contract with University of North Carolina folks that have a tractor-trailer type of mobile hospital unit that they brought down to set up right outside their emergency department so they could expand the space in which they were able to take care of patients. We currently, in public health, we have 8 inflatable hospitals, each one of which is a 50-bed facility, but it's a tent. It's not a hard hospital like the one that Grady has, and it's not ideal in weather like this, obviously, but we have made those available to hospitals that want to use that on their premises to expand the area in which they might be able to either triage or treat patients. Our only request has been that the hospitals be responsible for unpacking and repacking those units, which takes a bit of time when that occurs. So we're making that available. We've had questions about the availability of oseltamivir, which is the primary antiviral drug that's been used for flu. And there have been sporadic shortages across the state, predominantly the pediatric supply, but they have been sporadic. And typically, one area may run out for a period of time, and then as the supply chain catches up, they have it again. So we've not had any real permanent lack of the ability to have medication available to treat that. So very busy season, over 600 hospitalizations so far, over 55 deaths. I don't know what the total will be this week. At least 1 and probably 2 pediatric deaths. But the other interesting thing, and I failed to mention this about this particular strain of flu, and I have no explanation for this, typically seasonal flu impacts both ends of the age spectrum, the very old, the very young. Well, we are seeing the numbers in both of those areas impacted, but we're also seeing a huge number of folks in the 25 to 44-year-old age group that have caught the flu this year. And among the very young, the pediatric age group, even though the numbers are high, the death rates are low compared to many years. So it seems like, and I'm hearing many pediatricians tell me that although they're overwhelmed with the numbers of cases and the panicked parents out there, that actually the severity of the illness in the kids is not as great as they thought it might be. So that's a good sign. But I think the messaging I would like to get out to Georgia is seasonal flu is always dangerous. It's not the common cold. We need to be prepared for it. Immunization is still our best strategy. And then also the old-fashioned grandmother recommendations: wash your hands, don't touch your eyes, your nose, your mouth unless you have to. Don't shake hands with folks for fear that you'll transmit it. If you get sick, stay home, stay out of school, stay away from gatherings like this where you can pass it on to others. Those are just common recommendations that I think we need to remind people of every single year.
Thank you. Any other questions? Dr. Neal, just 2 comments I'd like to make and pick up on what you said on your prescription monitoring, drug monitoring program. I think it's where it needs to be, and that is in your department. And it's obvious that it's going to take resources to get that program where we would like for it to be, so that it's seamless and it's effective and it's basically real time, so you can tell what's going on. So we want to work with you on that, and appreciate what y'all are doing to bring that online and make it easy for the providers to use and keep the records that we need. And the other thing is the maternal mortality. I mean, we every one of us should be ashamed of where we are in Georgia and how we are ranked. I mean, we're worse than a third world country, and some of this is going on. And as you said, that's just unacceptable, and we need to really work hard at getting something done. So thank you for your efforts there. Anybody else have any comments or questions that they want to make before we adjourn? I want to thank you, Dr. Neal, you and your team for being here with us. I want to just remind everybody, the committee and others, we'll be meeting tomorrow in this room at 12:30 for public comments. Is she here too? What? LaShawn, where are you? You're going to have to stand up. I didn't see you back there. We were getting ready to leave. Come up here. We got a lot to talk about. I thought that was going too fast. The Physician Workforce Board. Thank you.
Thank you, Mr. Chairman and committee members, for allowing us to come and speak. Daniel's going to put our presentation up. I'll just start out by saying that the Board of Physician Workforce has 6 budgetary programs that we have: administration, undergraduate medical education, Mercer, Morehouse operating grant, the Physician for Rural Areas loan repayment programs, and our graduate medical education. For 17.11, it's a statewide change. There's nothing to add to that. Our administrative budget, in our budget, that's our personal services. We also have a new project called the Georgia Data Visualization website. We can look at the counties where you live and see how many physicians are practicing there. We have data collection and analysis. We compile reports and information about that, and we also have practice opportunity fairs where we have rural hospitals come in, and the residents rotate through there, and we do site visits to everybody that we give a loan repayment to. These are some of the types of reports that we produce: our annual reports, where people are with their scholarships, physician, PA, and data reports. We do that. We've been working with the nursing board to add nursing onto our data reporting. Our graduate 17.12 is for increased fundings for new residency slots. And we get this information from all of the programs. We survey the programs and ask, are you adding new residents? And this is what the ask is for that. It's $1.9 million. And the next slide is information on graduate medical education. It talks about the total residents, how many are under contract with us, how much the funding is for that. It's an FYI. 17.13 is Mercer School of Medicine. There's their operating grant. It's no change there. And the next slide talks about the operating grant, what happens. Mercer has 3 campuses, and it's information about their campus. We have Morehouse School of Medicine, their operating grant, no changes requested there. And it talks about, our next slide tells you more about what Morehouse is doing and how many students they have and the appropriations for that. Our Physicians for Rural Areas loan repayment program, we feel this is very important and crucial to help fund physicians and PAs and APRNs and dentists that agree to practice in rural areas. There's no change request there. And I do want to point out that we have allowed 36 physician loan repayment programs, 8 additional ones through a federal program where we get federal matching funds. We have 12 dentists, 40 APRN and PA loan repayments. So we're doing good work to keep more people down there. Our scholarship program is being phased out. We have 1 person left that's in our scholarship program, and then our accelerated track program in Savannah. Undergraduate medical education, there is no change to that. We're not requesting a change. And our next slide talks about how many students that we pay and how much the appropriation is and the rate per student. And our last slide is a summary of our budget and where our spending and funding is. That's it, Mr. Chairman.
Good, a lot going on over there. Do we have some questions for the director? Let's see, Representative Taylor has a question.
Thank you. This was a great report. I noticed on the type of physicians, we have a lot of them, and we have an aging population. Are we doing or adding any more geriatrics?
So that has not been one of the core specialties that we look at, but it is something, some information that I can provide for you.
Okay,
How many-
it's just, it is an aging, I know in rural
Right.
communities particularly, we've lost a lot of our young folks, and it's getting tougher and tougher. That might be something to consider.
Yes, ma'am.
Thank you.
Yeah. Anyone else? We've had some recommendations. I know that will come out of our Rural Development Council, and a lot of this committee has been very involved in the graduate medical education program and the residency slots, and through the governor's leadership, we've got those programs all across the state now that are really online and beginning to pump out some doctors, so they'll go in there. I still think we've got an awful lot to do to make our programs competitive with others. You know, one of the things when we met with some students around the state at the medical schools and in the colleges is the amount of debt that they have when they come out of school and what we could do to help them. And we've done some things, like we started the new program with the PAs and the dentists and that sort of thing. So we'll want to continue to look at that. And I think we're going to maybe have some legislation that you're putting together for us that'll address some of this, won't we?
Yes, sir.
That we'll be looking at. So we'll work on doing some of those things. Anybody else have any comments or questions before we really do leave this time? Thank you, Sean,
Thank
for
you.
you and your team and what you're doing over there. And we want to stay in close touch so that we can make sure we do the things that we need to do to improve the health around this state. Anyone else have anything before we adjourn? Tara, am I through now? Okay. All right. I'll remind you one more time, 12:30 tomorrow, public comment. She'll be here a few minutes before 12:30 if you want to sign up to be heard on any issues. And we thank you for being here and thank you for your interest, and we're adjourned.